Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We're so happy you joined us. Today's topic is pain is common, but treating it safely can be challenging, especially with medication risk and chronic health conditions. Today, we will discuss safer, more effective ways to manage pain in our communities. And I will now turn it over to our founder, Dr. Randall Maxey.
Thank you so much, Dr. Barbara Davis Stevens. Welcome, everyone. As you know, over the past 24 hours, we've gone to war. We want to pray for those souls that have been lost on all sides. And our topic today is going to be about pain and pain management. But in light of all that's going on, the fact that this is the Lent season, I want to spend a few minutes on dealing with the subject of fasting in a safe way. Can we go to the first slide, Simon? Are the co-moderators on, Dr. Neighbor Stevens?
Yes, Dr. Walks is with us. He's
All right.
muted, but he's with us.
So religious fasting and health. Let's go to the next slide. So why it is important to understand fasting. Fasting can provide meaningful health benefits when done safely. Medical risks may occur in people with chronic conditions or certain medications. Knowing both benefits and concerns helps you be informed and make informed decisions. Safe fasting integrates medical knowledge with spiritual goals. Next slide. So, why this topic is so important? Pain medications are widely used. The risks increase when they're combined, and there's a higher burden in African American communities, and we have a lot of deaths when you combine pain medications, sleep medication. That's going to be our main topic today. Next slide. So people who should really pay attention as we go forward, people with chronic pain, patients on opioids or sedatives, and people with hypertension, diabetes, or chronic kidney disease. Next slide. So let's go back to fasting and health. Next slide. So there are three major faiths that we celebrate in this country. There are others, but we're just going to stick with the three. The Christians, we're in the Lent season now. People who understand Islam do Ramadan, and Judaism, they celebrate Yom Kippur. All three traditions include fasting as a spiritual discipline, and fasting also connects believers to God through self-control and reflection. Next slide. So there's some shared spiritual purposes. Dr. Neighbor Stevens, would you take this one?
Okay. So, spiritual purification and renewal is a common theme. Repentance and forgiveness, as is prayer and deeper relationship with God. Self-discipline and self-control, and compassion for the poor and less fortunate. All of these are shared.
Next slide.
Common practices: temporary restriction of food and sometimes drink, increased prayer and worship, charity and acts of kindness, reflection on personal behavior and faith, community participation and support.
Next slide. Dr. Walks.
Still not unmuted, nor is Dr. Lawson.
Okay. Go ahead, Dr. David Stevenson.
Physical and health similarities. Changes in metabolism during fasting, lower insulin levels and use of stored energy, potential benefits for weight and metabolic health, need for hydration and safe fasting practices, medical considerations for chronic illness.
Those are all very important. Next slide I'll take. So there are differences in timing, but they have similar meaning. Is Dr. Walsh unmuted yet?
Not,
I
yes.
am. I just am. Thank you.
Thank you. Want to take this slide, sir?
Absolutely. Thank you, Dr. Maxey. Differences in timing, but similar meaning. Lent is a 40-day season with fasting, with partial fasting or food restrictions. Ramadan, daily fasting from dawn to sunset for 1 month. Yom Kippur, approximately 25-hour complete fast. So despite timing differences, the spiritual goals are very similar. Next slide, please.
Yeah.
Continue. Universal themes across faiths: humility before God, gratitude and awareness, self-discipline over physical desires, spiritual growth and renewal, and connection to community and tradition.
Next slide is Dr. Lawson.
Yep, here.
Want to take
Potential, can you hear me okay?
Mm-hmm.
Yes.
Potential benefits of fasting. Improved blood sugar control and insulin sensitivity. Weight reduction and metabolic improvements. Lower blood pressure and cholesterol. Possible cellular repair and inflammation reduction. Most importantly, perhaps spiritual focus, discipline, and emotional well-being.
Next slide. So potential health concern: low blood sugar, hypoglycemia if you have diabetes on medication, that's the concern. Dehydration if it leads to dizziness or kidney problems or low blood pressure. Medication complications can happen if you take your medicine without food. Muscle loss. Some people get very weak uh, and lose muscle weight during the fast. And it's also increased risk in elderly people, not like Dr. Hines. And if you're chronically ill, it can be a problem. Next slide. Dr. Abrams.
Who should be especially careful? People with diabetes, kidney disease, or heart disease. Individuals taking insulin, diuretics, or fluid pills, or people taking blood pressure medications. Older adults or those with frailty. Pregnant individuals or those with acute illnesses, and anyone with a history of fainting or dehydration.
And as a pediatrician, we don't encourage kids to fast, do we?
No.
Let me, Max and maybe will mention it later. Also, one other risk factor is, contrary to popular beliefs, African Americans do get anorexia nervosa. And unfortunately, sometimes continued prolonged fasting can play right into this potentially lethal illness.
Okay. Next slide. Dr. Walsh.
So balanced approach to fasting. Consult your healthcare provider before fasting if you have medical conditions. Hydration and proper nutrition are critical. Monitor symptoms carefully during fasting. Most faith traditions allow flexibility for health reasons. Your health and safety always come first. And may I add, as someone who does fast when my church has the fasting, I found out several years ago that I can't fast like the young people. I can't just do nothing but water for 4 days and then introduce slowly some nuts I have to do something different because a good friend of mine who's a physician saw me on day 4 and said, are you trying to kill yourself? I said, no, this is what the church is doing. I'm trying to fast. So I can't emphasize enough how important it is if you're going to fast with a group that you consult your healthcare provider if you have medical conditions or if you are over what's the age where you can't just up and fast, Dr. Maxey?
You want to make sure you're somewhere between 50 and 85. You can fast.
Okay, so if you're over 50, don't fast without consulting your provider. Or if you're under 50 and you have a chronic health situation that needs to be monitored.
Yes.
So,
Next
Dr.
slide.
Doctor, I want to just comment on what Dr. Walks was talking about. So, after prolonged fasting, I think what he was experiencing is called the refeeding syndrome. So, when you are having your conversation with your healthcare provider, uh, make sure you find out specifically what you should be on the lookout for after you fast when you start eating again.
Okay. That's good. That's very important. Next slide.
Dr. Maxey, I just want to mention one quick point, perhaps we can talk about it later. Fasting is also very common among athletes, especially in sports like wrestling, judo, and some others. There's one who chronically went on recurrent fasting episodes and saw some of the consequences of it. We've actually had people who died in terms of trying to make weight for some of these sports. So it's not just religious reasons, it's also for athletics and for competition purposes as well.
which
Okay.
which which goes directly against what Dr. Neighbor Stevens said earlier about children not fasting. But when you're weighing 8, 9, and 10-year-olds for a wrestling tournament, you've got to be very much aware, Dr. Lawson. That's extremely important.
Oh, yeah. That's true. So metabolic physiology benefits. So there are certain metabolic phases. When you cut your glucose intake down, that leads to a change in your glycogen, and fat leads to ketones. That means you're going to lose weight. There are hormonal changes that happen. Your insulin decreases, your glucagon increases, and growth hormone increases, and you tend to store more food. There's something called autophagia, and we'll talk about that as we go forward. There are benefits to get improved insulin sensitivity, which is important. You want that. You get weight reduction, and you may have some improvement of your blood pressure. Next slide. So, fasting and cellular repair. It's interesting that when you fast, this gives the body a chance to do something called autophagia. And I won't go into details on that, but it does allow you to get rid of pathological cells, dead cells, etc. Basically cleanses your body. So fasting is metabolically good. There are enzymes to take care of that. Next slide. So if you eat versus fasting states, eating frequently gives you high insulin, and that makes you gain weight if you eat more. That's something. The more you eat, the more you gain. And this is mediated by the same hormones that affect you when you fast and lose weight as well. So if you fast, it lowers your insulin and also is fat burning and allows the body to repair itself cellularly. So fasting is something that can clean you out inside. You don't need a cleansing. You clean your body normally. Next slide. A lot of people go through all these body cleansing things, but the body is magnificently made and will clean itself. Dr. Lawson, will you take this one?
Sure. Autophagia activation, which can lead to better metabolism, heart health, brain protection, and healthy aging. And I might add a little bit later, there is I used to work in eating disorders programs. Euphoria is also a common consequence in terms of some people who fast. And I can go into detail later, but suffice it to say, it can become pathological.
Thank you. Next slide. That's Neighbor Stevens.
So we are looking now at a graph that is looking at what happens with our metabolism, i.e., how does shifting toward fat utilization during fasting correlate with the length of time you're fasting. So as you fast, the longer you fast, the higher your curve of fat utilization becomes. So at hour 25, you are at 80% fat utilization if you've been fasting for 25 hours.
Next
That
slide.
might be 24 hours.
Dr. Walks.
Risks and medication considerations while fasting. Hypoglycemia risk is highest with insulin and sulfonylureas. Dehydration may cause hypotension and kidney injury. And I'm just going to add here, dehydration also can cause you to be dizzy and fall down. And if you're a senior, especially, falling is for toddlers. If you are over the age of 3, you should not fall down. SGLT2 inhibitors. If you're taking those, you can look for dehydration and ketoacidosis as risks. And then a lot of folks are taking GLP-1 now, GLP-1s now. GLP agents are generally safe, but you have to monitor your intake.
Next slide. Dr. Lawson.
Insulin dosing algorithm, general guidance. Basal insulin reduced 10 to 30% during fasting. Bolus insulin, dose with meals only. Frequent glucose monitoring recommended. Stop fasting if glucose less than 70 milligrams per deciliter or symptomatic. And I might add, the problem comes folks who take a little bit of insulin before they go to sleep. Because I've seen cases, multiple cases of folks whose insulin levels, whose blood sugar levels drop below 50 while they're asleep.
Next slide. Then David Stevens.
So now we're going to look at the relative risk of developing low blood sugars during fasting when you are on certain medications. The highest risk is with insulin. The next highest risk is with sulfonylureas. The next one actually is GLP-1s. And then after GLP-1s would be metformin. And the lowest risk is with regular diet.
Next slide. Dr. Walks.
Hypertension, cardiovascular, and chronic kidney disease management. So again, in consultation with your doctor, you want to make sure you are aware that you have chronic illnesses when you're going to fast. We can't overemphasize that. So you may need to adjust your antihypertensives if dizziness or hypotension occurs. Diuretics can increase that dehydration risk that we talked about. In chronic kidney disease stage 1 to 2, generally safe with hydration. If you have CKD stage 3 or above, supervision is recommended. And stage 4 to 5, you really want to avoid prolonged fasting.
A lot of individuals have stage 1 where they have minimal proteinuria. That's not as much concern. Stage 3 is a creatinine of about 1.4, 1.5. And those people, you have to be concerned about them. And stage 4 and 5, most of those people are either on dialysis or need to be on dialysis, and you want to avoid fasting with those groups. Next slide. Dr. Lawson?
Chronic disease prevalence in African American adults. Right up at the top, of course, is hypertension, greater than 50%. Okay. Diabetes, around 20%. And then chronic kidney disease, that's around 20%. And heart disease, again, between 10 and 20%.
Next line. So, Dr. Neighbor Stevens?
So this is the protocol that we would encourage you to discuss with your healthcare provider before you initiate a fasting period. So you want to talk about hydration, balanced meals, and review your medications. During it, you want to monitor your glucose, your blood pressure, and any symptoms, anything that's new that's happening. After the fast, you want to gradually refeed, and you want to use protein and fluids first. You want to stop fasting for dizziness, confusion, chest pain, vomiting, and I would encourage you to touch base with your healthcare provider.
So like you come off the desert and haven't eaten for a week, you better not eat all at once. Next slide. Dr. Walks?
Clinical pearls and patient education. Individualized recommendations based on comorbidities. This is for the practitioners, the providers. We need to make sure we individualize recommendations based on the comorbidities. Hydration is critical for kidney and cardiovascular safety and just all the time anyway. A lot of folks don't drink enough water, don't take in enough fluid. So hydration is critical. And if you're not going to be eating and drinking, definitely remember your kidneys need love if you're going to be fasting. Medication review prevents complications. Talk to your doc about what you're taking. Talk to your practitioner about what you're taking. Make sure that you understand how the medications may need to be adjusted or need to be maintained. If you're only taking medication with food and you're fasting, that could be a problem if you suddenly stop taking your medications because you're fasting. And this one is really, really important. Most faith traditions do allow medical exemptions. You are not going to get in trouble with your imam, pastor, priest, whatever, rabbi, because you are because you're unable. Your body needs you to do certain things that don't allow you to do, the Daniel fast or an all water fast or what have you. We just can't all do that.
Next slide.
Dr. Matthews, just want
Yes,
to
sir.
note one point that there are some religious positions that really try to encourage people to fast until they go into an alternate state of consciousness. That they're gaining greater spiritual insight as they become deeper into the fast and so forth and so on. So unfortunately, there are some religious traditions that ignore the health complications.
What do we do with those guys?
Good question. I have an answer. We don't allow them to put us in the hospital. Really, it's very hard to worship and tithe when you are in the hospital.
Especially can't tie very well. The pastor ain't gonna allow that to happen.
And so, I mean, Dr. Lawson raises a very important point. I think that there are people in your life who you listen to. One of them is your religious or spiritual leader. No question about that. And at the same time, they have an area of tremendously important expertise. And so does your nurse practitioner or your physician or your PA. They have an area that's tremendously important. And both of them matter. So I think Dr. Lawson raises a very important point. If you're listening to one of those people, if you have a doctor that says, look, you should not listen to anything your spiritual advisor says, you might need a different doctor. But if it's going the other way, you might need to check your spiritual advisor.
Yeah. And also, there's something called common sense we have to use too.
But Dr. Maxey, and I think some of you are aware that there's a gentleman in Kenya who's being prosecuted right now because he led to had involved in mass murder by encouraging his philosophers, his followers, to starve themselves to death. So the kind of religious experience in certain cultures can be very powerful in terms of encouraging people to ignore common sense and good medical practice.
Wow.
Okay, thank you. We got a couple of cases just to discuss. It might give us some direction here. So case number one, there's a 58-year-old man with type 2 diabetes on basal insulin and metformin. He wishes to fast for Lent. His hemoglobin A1C, which measures your glucose over the past 3 months or 90 days, was 7.4, which is not too high, not bad. No prior hypoglycemia. And the BMI is 32. At 32, anything above 30 is called obese. To get above 40 is morbidly obese. So one, you want to check out what your hypoglycemia risk is. Consider basal insulin reduction 10 to 20%. And encourage glucose monitoring. They have these little things you can put on your arm that measure your glucose and let you know whether it's going up or down. And discuss safe fasting signs when to stop. So even though these seem clinical, there's good common sense that you can use yourself. Next slide. Get about 3 of these.
Dr. Mackey, I just unfortunately want to discuss a case that I was involved with in which the person was incarcerated, unfortunately, decided to fast. I don't know who was doing it to get better help or whatever, but died with very similar kinds of numbers because between the times he was tested, his blood sugar dropped below 30.
Yeah. Yeah, I think it's, first of all, dangerous to be incarcerated, but the way these prisons are run now by commercial interests, they pay you no attention medically at all. We ought to have Dr. Bailey come and comment on that. He runs the health and the prison system in Louisiana, I think. So case number 2, 67-year-old woman with chronic kidney disease, stage 3B. Their EGFR is 42, normal is above 60, and hypotension on the ACE inhibitor, water pills, and wants to participate in religious fasting. What do we need to discuss? Evaluate dehydration risk, consider diuretic adjustment, monitor blood pressure and renal function, and discuss hydration strategy. So it seems this hydration comes up every time. You got to watch how much you're urinating and make sure you're replacing at least that plus some every day. Next slide.
Dr. Maxey, but before we leave this point, these are all the biggies, but even if you think that taking into consideration the risk of dehydration and what have you, there's another situation that fasting can potentially trigger in someone who has chronic kidney disease, and even if they don't have chronic kidney disease, and that is it can throw your blood chemistries all out of whack. And I mean, that's a medical term, out of whack. So,
I like that.
and it's a whack, all right. You can be weak, your heart rhythm can go crazy. It's serious. It's not a joking matter. So just fasting needs to be done with consideration and proper preparation.
Thank you so much.
Amen.
Let's go to the next slide.
One out point, I'm sure Neighbor Stevens is well aware of it. A lot of our, especially our young people, are on high dose caffeine drinks. And combined with fasting, they become dehydrated, not because of water deprivation, but because they're on these super high caffeine drinks. And there have been reports of deaths from people who own mega doses of caffeinated drinks.
Why don't you take this one, Doctor Lawson?
Yet elderly hypertensive patient. This case is a 79-year-old male with hypertension and mild frailty, taking multiple antihypertensives, plans to fast during religious observance. Discussion points: assess orthostatic hypotension risk, review medication timing, monitor blood pressure, consider modified fasting rather than full fasting. And I might add, I've seen too many cases, work with a physical therapy group, folks that have severe orthostatic problems, and especially among the elderly, aren't aware of it and ended up falling, literally falling, doing trivial types of behavior.
Good point. Next slide. This is the last one on these cases. Dr. Neighbor Stevens.
We are now going to talk about a healthy individual who wants to lose weight. She's a 45-year-old woman with obesity, but no chronic disease, who wants to use fasting for her weight loss during Lent. Well, I think there's some issues with that whole thought process, but discussion points. Discuss safe fasting approach. Emphasize balanced nutrition when breaking the fast. Encourage hydration and protein intake and monitor for excessive fatigue or dizziness. The reason I said what I said about some issues with that thinking process is that weight loss during fasting is almost certainly not going to be sustained once the fasting is over.
Yep.
Yep, that's true. But you can get started that way. You have to start someplace.
Well, starting is fine, but I didn't see anything about continuation.
And a lot of that weight loss is dehydration, the water loss. So the drinking gives you go right back up.
Next slide. Dr. Neighbor Stevens, take this.
Key things to know before fasting. Consult your healthcare provider if you have chronic medical conditions. You think we think this is important? What is this, the fourth or fifth time we've said this?
Right.
It is important. Medication adjustments may be required, especially if you have diabetes, high blood pressure, or use diuretics or other medications to treat whatever condition you have. Hydration is critical to prevent kidney and cardiovascular complications. You need to monitor yourself for things such as dizziness, weakness, or confusion. And most faith traditions allow medical exemptions for safety. A comment I want to make on the monitor for symptoms. If you're with a support system, i.e., if you don't live alone, you might want to make sure everybody's aware of what you're doing so that if you start acting weird, they know that they need to intervene.
Very important technical term there.
Next slide.
Me?
I'll take it. So who should use caution for fasting? Diabetics on insulin, hypoglycemics can cause medications, chronic kidney disease, stage 3 or higher, heart disease, heart failure in elderly, frail patients, people who are pregnant or acute illness, people who have a history of fainting, dehydration, or unstable medical conditions. Next slide. Take this one, Dr. Walks.
When to stop fasting immediately. If your blood sugar goes below 70 or you have symptoms of hypoglycemia, stop fasting immediately. If you have severe dizziness, fainting, or confusion, stop fasting immediately. Chest pain or shortness of breath, stop fasting immediately. Persistent vomiting or inability to hydrate, so you can't take in that water, stop fasting immediately. Marked weakness or inability to function, stop fasting immediately.
Next slide. Dr. Lawson.
Decision tree, diabetes patients. Step 1, is patient on insulin or sulfonylurea? If yes, high risk, adjust the medications and monitor closely. If no, moderate risk, educate and monitor. Step 2, prior hypoglycemia. Yes, consider modified fasting. Step 3, provide glucose monitoring plan and stop criteria.
Next slide. Dr. Neighbor Stevens.
Decision tree for someone with chronic kidney disease. Step 1, do they have chronic kidney disease? If it's stage 1 or stage 2, it's usually safe, but they need to drink fluids. Stage 3, supervision is recommended. Stage 4 to 5, avoid prolonged fasting. Step 2, on diuretics, yes, consider dose adjustment and monitor BP and renal function. And you didn't specifically put it there, but I want to highlight if you are on dialysis, whether you're on hemodialysis or peritoneal dialysis, you need to have a serious conversation with your provider.
Probably don't do it. Next slide. Dr. Walks.
Decision tree for an elderly patient. Step 1, frailty or a fall risk. If yes, recommend modified fasting. Step 2, if you have orthostatic symptoms. If yes, adjust medications and maintain good hydration. Step 3, monitor blood pressure and symptoms regularly.
Next slide. Dr. Lawson.
Decision tree, healthy individual. And I presume they mean physically healthy. Step 1, chronic disease, no generous safe fasting. Step 2, adequate hydration and nutrition. Yes, continue with monitoring. Step 3, symptoms develop, stop fasting and reassess. And I might add, these say healthy individuals. If the person has a history of eating disorders, I'd tell them to be very careful about getting into anything that requests supports fasting.
And I want to add an addendum to this one. Healthy individual as far as you know.
Exactly.
Well,
Okay. Next slide.
Oh, let me just mention one other quick point. I mentioned the psychiatric disorder. There's another disorder that we've talked about in the past, but there's also an increased risk in fasting. A person who's a chronic alcohol or substance abuser. They have all other kinds of complications that make fasting undesirable.
Very good. So why this topic is also important, we want to talk about pain medication. They're very widely used. The risks increase when combined, especially if you combine opioids with sedatives. You have a high rate of death that can happen from respiratory arrest. There's a higher burden in African Americans for this process. Next slide. So who should pay attention? People with chronic pain, people with hypertension, diabetes, chronic kidney disease, and patients on opioids and or sedatives should pay attention to this. Next slide. So types of pain medication include acetaminophen, which is Tylenol, NSAIDs, which is aspirin, ibuprofen, opioids like hydrocodone, and others, Narcan, and gabapentin, pregabalin, and muscle relaxants fall into this category. Next slide.
Dr. Maxim, just want a quick throw in because I'm interested, it's not there. Also, chronic alcohol use.
Yes, very true. So, Dr. Walks?
cardiovascular effects of pain medications. They can elevate blood pressure. They can cause fluid retention. They can increase your heart attack risk, and they can increase your stroke risk.
So one of the things that concerns me, Dr. Walks, I see patients every day. They, doc, I got low back pain. Give me some hydrocodone or give me some oxycodone. And they have no idea that these drugs can be very dangerous. So we want to discuss that as we go further. Next slide.
And Dr. Maxey, what Dr. Walsh mentioned before, fall risk for all of those.
Yeah.
So kidney effects of pain medication: reduced kidney blood flow, acute kidney injury, CKD progression, and electrolyte imbalance. All these can be very serious things when you take these medications. Next slide. Dr. Lawson?
Liver effects of pain medications: acetaminophen toxicity, liver inflammation, fatty liver worsening, liver failure risk. And I might also add that less of a problem now. Some of the older antidepressant medication is less of a problem now because of the new agents. So I have multiple sources, but it's also a potential risk.
Okay, next slide. Dr. Neighbors-Stevens?
Respiratory and brain effects, breathing suppression. Here we go, Dr. Lawson, sedation and falls, brain fog, and depression risk.
Next slide.
Well, you didn't put the other one, Dr. Maxey, that I see the results of frequently is irritation of the esophagus and stomach.
Yeah.
Yep, there you go. Take this one.
African
Walker?
American disparities in pain risk, higher chronic disease burden. We've talked about this a lot. Medication access differences and higher complication risk.
Next slide. Dr. Walks?
Naloxone versus Sublocade, how they work.
Take the next one.
This is all that research that Dr. Lawson is doing with Dr. Chapman.
Yep. Take the next one too.
Okay. Two medications, different purposes. Naloxone or Narcan, emergency overdose reversal. Kicks opioids off brain receptors, restores breathing quickly, works in minutes, short acting, lasts 30 to 90 minutes, and it's used during an overdose. Sublocade is a buprenorphine injection. It's addiction treatment. Stabilizes opioid receptors, reduces cravings and withdrawal. It's a monthly injection, long acting, one time a month, used for recovery treatment. Mechanisms. Naloxone blocks receptors completely, reverses overdose. Sublocade partially activates receptors, prevents withdrawal and cravings. And I'll say that naloxone reverses overdose, but can precipitate acute withdrawal as well, if I remember correctly, Dr. Lawson.
Yeah. So one is a treatment for overdose and one is a treatment for avoidance. Next slide.
That's also, and I'm sure Dr. Walsh is well aware of this as well, naloxone is a very common ingredient in certain dietary products. Used combination of bupropion is used. It's a very effective weight loss medication.
Okay. Want to take this slide?
Medications, alternatives for pain is typical NSAIDs, duloxetine, physical therapy, nerve blocks, non-opiate medications, and of course, cognitive behavioral therapy.
What about treating what's causing the pain in the first place?
Cognitive behavioral therapy.
Yeah.
No, it could be a physical complaint that has been undertreated.
Right, right.
That's true.
And something else to add with this slide. When I see duloxetine, I think mental health as opposed to a pain medicine, and it just highlights the fact that whenever your doctor prescribes any medication for you at any time, really understand what the target is for the medicine, because one medicine can be prescribed for more than one thing. So you need to be, and the reason that's so important is you got to know what to look for. How do I know this? How do I know the thing that the doctor is working on or the practitioner is working on is getting better if I'm not sure what the target is for the prescription?
And just to note,
One of the guys I like best is Shaq. He is icy hot. The more topical stuff you can use for that back pain and other thing, the better you are not putting anything in your body. Icy hot, whatever else have to put on your outside. Try not to take anything orally if you can get away with it. I have back pain, but I rarely take anything in my mouth for pain. Rarely. Next slide.
yeah, Dr. Max has one, and also for the group doesn't. Duloxetine and related agents, their effect isn't just, quote, psychiatric, because their pain reduction effects is also seen in animal research as well. So it cuts across. It's much more than just. It's usually used as an antidepressant. It's much more than an antidepressant.
Why don't you take this slide?
Non-medication pain strategies, exercise and stretching, weight reduction, anti-inflammatory diet, heat/cold therapy, stress reduction.
So one of the things I have patients come in, they weigh 400 pounds and say, I got knee pain. How can you have a stress-bearing joint and not have pain if you weigh too much? So weight loss is something very important. But again, I stress, the more you can do without putting anything in your mouth, you're better off with that. Next slide. Dr. Neighbor Stevens.
Why pain medications plus sleep apnea is dangerous. Sleep apnea is a condition where you have, excuse me, prolonged pauses in your breathing during sleep. It has various causes. We won't get into that. But sedation worsens one of the causes for sleep apnea, which is collapse of the airway. In other words, it closes down. Oxygen drops increase. In other words, your blood oxygen levels go down. There is a pattern normally in sleep, but this is increased when you are taking pain medications. And then there's a higher risk of death during sleep if you have sleep apnea and you're taking pain medications.
Next slide. Should be at the end. Take this from Dr. Walks.
Key takeaways. Pain medications affect multiple organs. Sleep apnea stresses your heart and kidneys. African Americans face higher risks. Treatment improves outcomes.
I think that's the last slide. Any more, Simon? Okay. So any comments or questions in the chat, Dr. Neighbor Stevens?
No, not at this time.
So we're pretty much at the top of the hour. Any other comments from our co-moderators on the issues of pain and medication, or even about fasting risk?
Well, I want to go back to the pain a minute because I wasn't just trying to be funny when I said treating the reason you have the pain in the first place. I can't tell you how many situations I have seen where assumptions were made that were incorrect and treatments were initiated which were totally inappropriate because they were not addressing what the actual problem is.
Give an
So,
example.
well, the classic one is a Black woman going in complaining of a mild fullness feeling in her stomach or chest. She may not localize it very well. And this is notoriously symptomatic of an acute heart attack. unlike a man who is going to more likely complain of pain radiating to their jaw or down their left arm. Plus, there is an ongoing assumption that women don't have heart attacks.
Right.
Yeah, I think it would be very inappropriate to give pain medication for chest pain in any case. You want to make sure you get enzymes, look at an EKG, take a good history. So that you're very right. That's a wrong way to approach that particular thing. I think this pain talk was more aimed at skeletal pain, back pain, knee pain. In my area, we have a lot of gunshot wounds 20 years ago, but people still say my leg hurt, I got a bullet in it, and they mess up their kidneys for that sake. So definitely not chest pain. And I'd also be concerned. I had a young, one of my nieces over the weekend had the worst headache she'd ever had. Went in, turns out she had a dissecting aneurysm at C4. So that was very difficult. So fortunately, they looked at her and looked at her vertebral arteries, and there was a problem.
Dr. Maxey, I just want to know, just follow through what Dr. Neighbor Stevens said. There's a lot of cultural gender issues involved with this. There's a famous University of Virginia study that showed that most of the medical students were convinced that African Americans had greater resistance to pain. And because of cultural issues, they're less likely to complain of pain when in fact pain was present. Also, I had a colleague who's a psychologist whose mother died. She presented with pain. He treated cognitive behavioral therapy. Unfortunately, she had a brain tumor and missed completely. And the diet thing, I just want to note one point, that is that culturally, African Americans have been protective because we are much more tolerant towards a little bit of obesity. But unfortunately, because of some folks becoming very much indulged into Western values, feel that having the kind of what we call twiggy bodies, losing weight is positive. And so we have a lot of people who are chronically going back and forth in terms of trying to get weight gain. And we have a number of different situations now, not just in terms of fasting for religious reasons, but also for athletes, people, dancers, gymnasts, and a whole group of other folks who go on fasting for their performance and also to presumably improve their performance.
Well, thank you. And while we're at it, why don't we get your final comments for today, Dr. Lawson?
So I just want to note that the important point is that pain and weight loss are important, have to be looked at. The perfect example of how we have to look at not only the individuals in terms of their physiological effects, but look at the cultural milieu and also look at some interpsychic issues as well. All of these can come together to be disastrous for people who try to look at this in isolation. We need to look at all of them, and we need to talk to the individuals who encourage folks to do things like diet, set a certain kind of body type. Not only the physicians, but also the ministers, as well as our coaches and athletes, and as well as our fashion designers. All of them need to be aware that we need to do what's necessary to maintain health above all else.
Thank you very much, Dr. Lawson. Dr. Walks? So,
Dr. Maxey, don't get mad at me, but I'm going to take issue with something a lot of us doctors do. We tend to give people numbers, and my question is this: one of you guys can tell me what is a normal A1C for somebody who doesn't have diabetes? Isn't it like 5.4 or something like that?
Around 5, 8, 5, 9.
Yeah. And then I know. And then we tell people that, and it was in an earlier slide, and it's been in many other slides. We tell people If you have diabetes, we want you to keep your A1C around 7.4. What about 6? We just skip right past 6. We tell people normal is 5.7, it's 5.4, but then we tell you to keep it. It is harder if you have diabetes to keep your A1C below 7. But I don't think we should have everybody thinking that the magic number that we really want you to keep at is 7.4, because then if anything else goes wrong, now you're at 7.9 and 8 and 9, and bad things are happening to your kidneys and your eyes and everything else. So I think if somebody without diabetes is at 7, is it 5.4, 5.5, whatever it is, maybe we should encourage people to work very closely with your practitioner and your doctor and see if there's a way for you to use diet and exercise and the appropriate medication and close monitoring and all of that. Maybe try to surprise your doctor with a 6.
Those are good points, Dr. Walks. Good points. Good points. In fact, I may share one of these weeks how we do chronic disease management. And we try to get it down to less than 5.9. But for many people with diabetes, and especially with CKD, it's very hard to get that down. There's a 3-month period we have to deal with. I'll give a talk on that coming up. It's a good point.
Great.
Dr. Barbara Davis-Stevens?
Well, I want to bring up something that I found, I guess, interesting and not surprising. There was a report, I believe it was from the CDC, that they are becoming concerned that they are seeing an increase in the number of poisonings or overdoses of the GLP-1s particularly. And they feel that it is because, one, it has not been good communication between the provider and the patient as to how much they should take and what adjustments should be made. Two, that a lot of the prescribing is being done online without actual physical one-on-ones. I mean, they're online one-on-ones, but they're not physical one-on-ones where one would presume better relationships could be established. And three, people deciding that they know how to adjust the medicine themselves and getting themselves in trouble. Which brings me back to let's use some common sense.
I might add, and
Very important. Very important.
yeah, I just want to note that there is a very famous athlete who's going around talking about how he's strong enough to overcome the medication by eating enough.
Mm.
Yeah. Well, next.
My final comment, I want to, again, give honor to those who are disciplined enough to do religious fasts and get closer to God.
Yes.
Also know that there are benefits physiologically, metabolically, and health-wise if you fast and do it correctly, and make sure you're well hydrated, and make sure you take allegiance to the various medications you're on, talk with your provider on those. And I want to, Dr. Gibson, I hope you got a set of slides. I sent them to you. And Simon, I'd like to talk to you after this call. And thank everybody for joining us. Thank you, Dr. Lawson, Dr. Walks, and Dr. Barbara Davis-Stevens.
Yes.
Have a great day.
Bye, everyone.
Good day, everyone.